We are going to dive back into things with our Director's Session Part 2. I'd like to welcome back up to the stage Dr. Sanjay Asana, the Director of Wisconsin ADRC and Chair of our ADRC Executive Committee.
Thank you, Hannah. Welcome back to the scientific presentations of the Director's Session. What I want to do is to start this session by celebrating with you all the major contributions that the ADRC network research has made to the field of AD-ADRD research. We've talked multiple times that the remarkable advances and really the landmark discoveries in the area of AD dementia research is just very impressive and phenomenal. What I want to share with you is my view that those advances that we have made in AD dementia field and the lessons we have learned over decades of research in that area are directly relevant to the scientific theme of this meeting, which is coexisting pathologies and the diseases that these pathologies represent. So really, it is our responsibility now to use the lessons that we have learned over the many decades in AD dementia research, apply them to research in non-AD dementias and coexisting pathologies, and make that field really accelerate and make some discoveries so that we can address all these non-AD dementias and the coexisting pathologies. So I've got no disclosures for this session either. You know the theme of this session. And in the next few slides, I want to make a case that how AD dementia research will accelerate research in non-AD dementias and coexisting pathologies. So in the area of neuroimaging and fluid biomarkers of Alzheimer's disease that we made amazing advances, we already have well-validated blood-based biomarkers of amyloid and tau deposition. At the same time, we have markers of various mechanisms, molecular mechanisms that underlie AD pathology, namely neuroinflammation and neurodegeneration. Now, the information we've gained from these biomarkers can be directly applied to discovery of biomarkers for non-AD existing pathologies. Now, in the area of those existing pathologies, some advances have been made. You all have heard about the seed amplification assay, which is for alpha-synuclein deposition, and also the skin biopsy, which can establish alpha-synuclein deposition. Believe it or not, the sensitivity and the specificity of SAA and the skin biopsy is between 97 to 100%. That's in literature. I don't know of any diagnostic test for any disease that may have a sensitivity and specificity which is so high. So once again, the seed amplification assay and the skin biopsy are some advances in establishing alpha-synuclein deposition and related diseases. Another real advance is the alpha-syn the neuronally derived extracellular vesicles and alpha-synuclein assay in these vesicles. This could be a potential blood-based biomarkers for alpha-synuclein. And also in the area of TDP-43, you all are aware of the cryptic exons that really through which we can detect TDP-43 loss of function. That is another potential test, the fluid potential biomarker for TDP-43. So there's some advances being made in the area of biomarkers for alpha-synuclein and TDP-43 as well. But in addition, we are really applying the knowledge we've gained from AD research to the biomarker field for these diseases. In the area of prevention and treatment trials, for the first time, we got the FDA approval for disease-modifying therapies. We know how many failures we had before we got the approval for these medications. And the lessons we learned from clinical trials of previous therapies that were not successful in Alzheimer's disease, the trial design issues, the kind of participants who should be enrolled in these trials, the AD biomarkers that we should measure to measure the effects of therapies. All that information from AD treatment research now can be applied to non-AD dementias and therapies for these coexisting pathologies. Another area that we as an ADRC network have truly made advances, and we all are working together, is to diversify our ADRC cohorts. So we are collecting information in various races and ethnicities, and we have biospecimens from diverse populations. Now, how about using that information to advance the field of diversity in non-AD dementias, and also use these biospecimens to measure biomarkers for coexisting pathologies, because these specimens are from diverse populations. So just think about the advances that we made in AD dementia research, how beneficial and relevant they would be as we enter the field of non-AD dementias and biomarkers for coexisting pathologies. The area of social exosomes, social determinants of health. I don't think any one of us will doubt that these factors are important for diseases like Lewy body, for Parkinson's disease dementia, and other tauopathies. It is highly likely that these social determinants of health, which really work upstream in the pathway for AD dementia, are active in non-AD dementias as well. So all that information we have learned can be applied to the other diseases. The early diagnosis of Alzheimer's, we really have ways through imaging and fluid biomarkers to diagnose the disease in pre-symptomatic stages. The same can be done for non-Alzheimer's dementias using the information and the knowledge we have gained from early diagnosis for Alzheimer's disease. You've heard of the Eureka Challenge. Now, Eureka Challenge is the prediction of dementia in marginalized populations through inclusive algorithms that are applied to large data sets. Right now it's for Alzheimer's dementia. Again, as we create large data sets for non-AD dementias, we can apply the Eureka Challenge to those diseases as well. And finally, the Impact Collaboratory, which is the pragmatic trials for people with dementia. Again, those trials could be also applied to non-AD dementias. So truly, these are spectacular times and a prime opportunity for us as the ADRC network to accelerate research in non-AD dementias and coexisting pathologies. Many of you have heard of this position paper published early this year in Lancet Neurology, which proposed to group all the alpha-synucleinopathies under the heading of neuronal alpha-synuclein diseases, or NSDs. The diagnostic criteria for these diseases are two, really. One of them, you have evidence of pathological neuronal alpha-synuclein deposition, and the second criteria is evidence of dopaminergic system dysfunction. And many diseases will fall under this new classification, and these diseases include Parkinson's disease, Lewy body dementia, multiple system atrophy, and autonomic, pure autonomic failure. Those kind of diseases now will be grouped under NSDs, and they have common shared mechanisms, and hopefully the biomarkers will soon be developed for these group of diseases, and advances are being made to really find treatments for these diseases. I want to share with you, this is my last slide, in the area of seed amplification assay. We at Wisconsin ADRC have got some pilot data which we think are exciting. And by the way, these data in a form of a manuscript are available in medRxiv. So you can download this paper now as you wish. It is freely available. So what we did from the Wisconsin ADRC, about over 400 participants enrolled in the Wisconsin ADRC clinical core and the RAP study. The SAA was performed by Emprion, that's the company that developed this assay. And interestingly, what we found that in dominantly cognitively unimpaired people, that the prevalence of SAA was in about 12% of these people. They have no symptoms, but 12% of this sample size had positive SAA. And also in people who had tau, it is the soluble tau, because this is in CSF, not fibrillar tau. But those who were positive for tau, the positivity of SAA rose from 12% to 20%. So it looks like that alpha-synuclein as a co-pathology is present in a good number of cognitively unimpaired participants. Now, these are very preliminary data that need to be replicated by us in a larger cohort by many of you over time. But these are interesting findings, shows us the prevalence of alpha-synuclein in randomly selected participants. So you can get access to this paper through medRxiv. So with that brief introduction, I would like to start our scientific presentation. The first presentation will be, and excuse my accent, I don't think I can say it right, but Dr. Renaud Lajoie. I know I'm wrong, but my apologies to you. And he's going to talk about pathology validation of AD biomarkers. He's from the UCSF ADRC. His research interests are on multimodal imaging and fluid biomarkers of Alzheimer's disease. He is at this early stage of his career. He's an assistant professor at UCSF. He has published over 160 papers and has significant funding. So please join me in welcoming Dr. Lajoie to make his presentation.
Thanks a lot, and I'm never mad at how people pronounce my name, because I probably mispronounce everyone's name as well. I am really glad to be here, and these are my slides. I will be talking about the pathological validation of Alzheimer's biomarkers. I will talk a little bit about how it's been done in the past, but also trying to emphasize some exciting data that is currently being done, and hopefully talk about the future of those studies. My disclosures, mainly personal, that my training, and I think it will show in the slides, is originally in neuroimaging and neuropsychology. And I really got very lucky to come into my postdoc at an ADRC. I didn't really know what it was, coming from France, but because it gave me an amazing exposure to other fields, especially neuropathology, which I really love now, and I love hanging out with neuropathologists in our site, and also getting more familiar with the fluid biomarker field that is incredible and incredible for the field and the patients. So I only have less than 15 minutes. I will not cover the whole field, but I will talk about a few key points. I think it's very obvious to everyone that when we think about why do we care about validating biomarkers with neuropathology, the first thing that comes to mind is that we want to make sure that we interpret the biomarker data correctly when we're trying to rule in or rule out the presence of Alzheimer's pathology. But we also need to remind ourselves that it's very important to have validated biomarkers when we use those biomarkers to study disease mechanism. We want to make sure that we interpret this data correctly. I also want to acknowledge that not all biomarker data needs to be neuropath validated. Biomarkers can be useful and clinically relevant for prognosis, regardless of their neuropathological underpinnings. I will talk about the previous validation of PET imaging. Again, my little bias as a neuroimager. Amyloid PET was validated and approved for FDA, by the FDA based on a few studies that were all based on a visual binary read of the amyloid PET scan, and the standard of truth, the gold standard, was neuropathological evaluation of amyloid and specifically neuritic plaque density. And you can see that these studies all showed high sensitivity and specificity of the visual read to detect those neuropathological stages. Tau PET followed the same pattern, for now with fluticasone being FDA approved. Again, the PET scan is approved based on the visual read that is binary, and the standard of truth was to detect a Bragg stage of 5 or 6. Again, same kind of process and study using antemortem PET imaging and postmortem data. But I want to emphasize that in both these cases, both the imaging or the biomarker and the neuropathology are being considered as binary variables, and I want to really try to emphasize that we can probably do a little more than this. We looked at amyloid PET. A few years ago, we combined a lot of data from multiple ADRCs and a group in Australia. We gathered 179 PET scans for patients who had autopsy. We quantified those PET scans with the Sentinel scales. It was kind of new at the time. Now it's really broadly used, and this is great because it allows harmonized quantification of PET scan across centers. So 0 means it's the average of negative scans, so scans of people who don't have amyloid in their brain. And 100 is what you see in typical mild to moderate AD dementia cases. When you plot centiloid values against tau phase, so another measure of amyloid pathology or autopsy, you can see that there's really a stepwise increase. Maybe at very early stages of amyloid pathology, tau phase 1 and 2, you don't really see clear elevation, but then there's a stepwise increase. And you really see that the data is not binary, there's really a gradient. And so it's a little hard looking at this to determine what threshold we use. How would you binarize this data? And actually, what we decided to do is to not choose a single approach, but look at a bunch of different neuropathological-based standard of truth. And I think what I really want to emphasize is that we can probably think about imaging and biomarkers in general as more than just binary. And we typically consider that centiloid values around 10 or between 10 and 15 are a good threshold to detect the presence of early stages of amyloid pathology. And you can take the problem the other way around and try to use those biomarkers not to just detect amyloid, but to detect a certain burden of pathology that qualifies for high ADNC. So it means patients who have amyloid, but also advanced tau stages. And in that case, the centiloid threshold would be 60. So you can see, maybe we can think about different tiers of biomarker values to better interpret the data. This is not specific to amyloid. Here I'm showing you Bragg staging, so staging of tau pathology, versus the amount of tau PET signal in the entorhinal cortex. You also see the same pattern of early stages not really showing any increased biomarker value. This is not specific to PET. This is another approved biomarkers based on CSF that also shows that at mild to moderate Bragg stages, you don't really have a systematic and very clear elevation of the biomarker value. Same with the emergent and very exciting blood-based biomarkers. This is p-tau217. And here you can also see that at high Bragg stages, the biomarker values are very high, but intermediate cases is not really, intermediate stages is not really the case. And I think here, again, we need to think a little more about how we use the neuropathology. And all these studies I showed are using Bragg staging, which is this canonical description of the progression of tau in the brain. But Bragg staging is really not a great metric of tau burden. And this is the amazing data from the Rush Center, where they've been quantifying the actual tangle density in different brain regions. And what I'm showing you here is the density of tangles in the entorhinal cortex, so the very first region, cortical region, that get tangles. And you can see that as tau progresses throughout the brain, tau continues to accumulate in the early regions. But the burden is really low at low stages. So at Bragg stage 1 and 2, patients have very minimal burden. And it's very likely to think that the in vivo detection with biomarkers, whether they're PET or fluid biomarkers, might not be able to detect those low amounts of pathology. So again, pathology is not binary. You can have different burdens. Even for, you can see here, a group of patients with a Bragg stage 4, there's a lot of variability in how much tau they have. Bragg stage 4 just means that they have tau in different regions, but in the early regions, they might have different values. The other thing is that pathology has a lot more, is very rich and has a lot of qualitative information. And this is, again, amazing data from the Pittsburgh ADRC, where they looked at how different types of amyloid deposits would result in different amounts of amyloid PET binding. You can see two plaques. One on the left is a cord plaque, and the one on the right is diffuse. And the amount of tracer binding is very different. And they identify that a single cord plaque gives you the same amount of signal as around 3 diffuse plaques of the same volume. So if you're just trying to validate PET or imaging or any biomarker based on a number of plaques, you might be missing a little bit of that information. And PET signal could be more of a function of the global amount of amyloid burden, so not just the plaque, but also their amyloid content. And the same go with tau. Tau, the Bragg staging is just looking at differences in tangles, but there's a lot more. Here you can see that tau PET signal in a single patient correlates with both tau-positive neurites and neurofibrillary tangle, and maybe even more with the neurites. And even when you think about tangles, there's a lot of variability. And Melissa Murray in her lab at ADRC in Florida, the Mayo Clinic in Florida, have shown that there's a gradient of maturity levels for tangles. Not all tangles are created equal, and some of them will have different biochemical property that probably will lead to different biomarker affinity. There's also, when we think about neuropathology to validate biomarkers, there's fundamental issues that we need to keep in mind about the samples. Of course, there's always the issue of the time between when you acquire the biomarker and a patient's death, but there's also very important features of who makes it to those samples. We know that, in general, the field is really oversamples white, educated, and urban participants, even more so biomarker studies, and even more so brain donation studies. So those data sets are really lacking representativity in general. And it's not just about who makes it to those studies, but also we need to think a little more thoroughly about who are the patients in those studies with pathology who don't have high level of pathology. And this is an example from our center. Looking again, I showed you this plot before. p-tau 217 increases with increasing Bragg stage. But when you look at other biomarkers, this is NFL, so a biomarker of neurodegeneration, you have this weird trend where patients who have more advanced tau pathology have lower levels of neurofibrillary tangle. And this is really just a collider bias. Again, because people who make it to those studies are very specific people. In our center, people who are likely to be enrolled and to be part of our brain bank and have low Alzheimer's pathology, they are likely to have high FTD pathology. And this can create those correlation and those associations that are a little counterintuitive. Another thing that is really important to think about when we think about the validation and the validity of biomarkers, it's not just their accuracy to detect the underlying pathology. We need to think about their interpretation in context. And this might be the neuropsychology training. But the way I think about it is almost like a hemi-neglect. We might have biomarkers on the right that are really good, or let's imagine they're perfect at detecting what's going on in the brain. It's complicated because we don't have access to the whole landscape. If the biomarkers are negative, and we're assessing a patient who has cognitive decline, we'll say, oh, well, the cognitive decline can be explained by all these other things that we can't see. The problem is that when the biomarkers are positive, then we don't know if Alzheimer's pathology is the only one or even the primary one. So it's really important not just to make sure that the tracers and the biofluid markers correlate with the underlying pathology, but to interpret, to enrich their interpretation in clinical context. And the last thing I will say is, again, talking about the future, neuropathology-based validation of biomarkers was mainly to know if we're able to detect pathology, and now we want to understand what's going on with the new treatments. As you all know, one of the main features of those anti-amyloid monoclonal antibodies is that they reduce amyloid PET signal, and amyloid PET can become negative. And we can see this in around a third of patients treated with aducanumab, and 2/3 of patients treated with lecanemab and donanemab after 18 months in the trials. We need to understand what that means. We need to understand what this treatment-related amyloid clearance reflects in the brain, how much amyloid is left, but also what kind of amyloid has been impacted. It's really not that straightforward, and we should not be making assumptions about what those treatments do. And of course, today there's no report of patients with, who have turned amyloid negative on their PET scan with treatment, but we have some cases with partial clearance. You can see here a case was treated and the amyloid PET signal decreased a lot. At autopsy, neuropathologists did see a decrease in the amount of amyloid plaques, but also changes or unusual features of the specific morphology of those plaques. At UCSF, we had 2 patients treated with aducanumab with mild exposures. And you can see they only decreased a little bit in their amyloid burden. And what was interesting is that the neuropathologists didn't see anything unusual when they looked at the brain. The amyloid pathology in those patients looked normal, both in terms of quantity and morphology. So again, it's helping us to have neuropathology on those cases to understand how to interpret the biomarkers in the context of those treatments. So just to summarize, in the future, of course, we'll need, and we've been mentioning this a lot today, and I think the next talk will talk about this as well, more diversity in the sample, because we need the samples, the biomarkers, to be validated in the population we want to use them for. We probably want to use more nuanced analysis of both biomarkers and neuropathology, and digital pathology is probably going to help us with this. We want to make sure that no matter how good the Alzheimer's biomarker are at detecting Alzheimer's neuropathological changes, the clinical interpretation will take everything into account, including the other biomarkers. And the exciting emergence of those treatments for us to understand how they work and how they impact biomarkers and what it reflects in the brain. So I'll just thank you all for your attention and thank everyone who's taught me a lot over the last years. Thank you.
Thank you so much for that outstanding presentation. We have, of course, a panel discussion. There'll be a lot of time for you all to ask questions from our presenters. It's a pleasure to introduce the next speaker, Dr. Rosie Curiel-Sid. Dr. Sid is Professor of Clinical Psychiatry at University of Miami, Miller School of Medicine. She's also Chief of the Cross-Cultural Neuropsychology and Cognitive Neuroscience Program. She's leader of the Florida ORCOR, and her research interests relate to development of sensitive cognitive tests and their translation into detecting preclinical disease. To that end, she uses state-of-the-art technologies, including visual reality, voice recognition, and machine learning. Please join me in welcoming Dr. Sid. Her presentation will be on significance of diversifying the ADRC cohorts. Thank you.
Okay, everyone, thank you so much for the opportunity to be here today. I'm just so thankful for the executive committee of the ADRC to invite me and share a little bit more with you about what we are up to at the University of Miami and also, of course, in the One Florida Alzheimer's Disease Research Center. And I really thought today was such a great meeting. You know, we really learned so much about how transformative it could be when our research participants take up that role of citizen scientists and really join us in our efforts, and that's really what's going to make the difference. So I really am so proud of what I do as ORCOR leader. I really believe it's been a gift in my life, and I dedicate this talk to all of our wonderful participants and their families. So as we all know, in only 15 years, we are going to be facing a tremendous boom in our aging population. And that's very significant. But what's also very significant is that 34% of those in our aging cohort in the United States are going to be individuals that identify as a member of a racial or ethnic minority. And that's the equivalent of over 26 million older adults. And in those projections, over 83% of that increase is going to be among older adults who are currently not well represented in our research, as opposed to 19% of white non-Hispanic individuals. So that's very important to take into account. And this is really going to transform the face of aging Americans in our country. And so when the NIA and the ADRC leadership admonishes us, please diversify your cohorts. This means that every single one of us, every center in our country is really asked to extend themselves beyond the comfort of their own regional demographics and to actively recruit not individuals that currently reflect your demographic, but recruit into these future projections now, because our ADRCs represent the leaders of America's most wonderful infrastructure into AD and ADRD research, right? It's us, it's on us, and so we really have to do better. This map shows the prevalence of Alzheimer's disease in all 50 states. Florida is one of the top 5 states with residents who are 65 and older. My county, Miami-Dade County, is ranked #1 among 10 counties in the nation that have the greatest prevalence of Alzheimer's disease. And Miami-Dade County is also among the most diverse regions in the country. And this very highly disparate prevalence of Alzheimer's disease in such a diverse community like the one we have in Miami, it just really highlights and just puts those two things together, really highlights the need to better understand the structural and social cultural drivers of Alzheimer's disease and non-Alzheimer's disease dementia in understudied populations. It's really a wonderful example of that. And you really think about culture, and it's not so much about race and ethnicity. We know that. It's more about the intersection of so many things, but also culture, which is the way that we live our lives. These are our shared beliefs, our health behaviors, the way that we interpret relationships, whether we decide that it's right for us to go and seek a diagnosis, or if and when to engage in care. All of these things, as we know, is influenced greatly by culture. So the One Florida Alzheimer's Disease Research Center, we're very committed to exceeding that demographic representation of Florida so that we could explore this intersection of biology and cognition and the way that people live their lives in order to just be able to understand a little bit better the intersection of this with disease onset and disease progression. So on the left, this chart depicts the older adult demographic population of Florida. You'll see it's about 15% Hispanic, 70% white, and 15% African American or Black. And on the, I guess for you, it's on your left, you'll see that One Florida ADRC's target population. We've pushed the limits of what we believe we can do in terms of recruiting a more diverse cohort. So here, we deliberately set targets out in our ADRC to recruit 20% Black African Americans and 40% Hispanic individuals, as well as 40% non-Hispanic white individuals. And this is just a few months old, but a graph of our active cohorts. As you can see, we exceeded recruitment of our proposed African American individuals, where they now represent 35% of our cohort. And we're well underway of meeting our Hispanic targets by next year. And I really want to illustrate the impact of a concerted effort to diversify your cohort. So in 2020, the One Florida ADRC was among the least diverse centers in the country when it came to the inclusion of African American older adults. But 4 years later, we're second only to the University of Alabama in terms of our inclusion of African American older adults. Our Hispanic Latino diversity, we're also very proud to be the runner-up for the ADRC with the most Hispanic Latino older adults to our friends in South Texas. And something quite special, though, that you should know about the Hispanic Latino heterogeneity of the Alzheimer's Disease Research Center in Florida is that it represents over 17 different countries: Cuba, Puerto Rico, Colombia, Venezuela, Panama, Peru, just so many countries. It's very rich. And our estimates for retention show that the probability of retaining individuals into the next cycle seem to be comparable across the different cultural groups. So that's really good. So if you diversify your cohorts, when you diversify your cohorts more, what kind of issues are you going to have to contend with? I'm going to share with you some of the issues we've had to contend with and some possible solutions that worked for us. If you see in this chart, it's very busy, but if you pay attention to the yellow boxes, in our cohorts, we found that Hispanic Latino individuals and white non-Hispanics were fairly comparable in their rates of clinical AD diagnosis and their amyloid PET positivity. But the same wasn't true in our Black or African American participants. They had substantially lower amyloid pathology on PET, and fewer were ApoE4 carriers. And so this brings up, of course, the likelihood of all these non-AD drivers of dementia risk. But to address this and any other potential selection bias, what we did was we met our targets, and then we really went in for a selective recruitment and targeted recruitment. So we tried to connect with every primary care doctor and geriatrician that served Black and African American communities. We upped the memory screening programs. We increased that and did everything that we could in order to enrich our sample with more targeted recruitment. Also, among the Black and African American individuals in our cohort, if you notice, it's very different who their CDR informant is. More so, it's likely to be a friend or a neighbor rather than a spouse or a child. And this presents its difficulties because, whether that CDR actually gets completed or if it may impact the reliability, for example, of the collateral informant, we tried to address that by making sure that we educate individuals that it's very important that they can identify someone who can reliably speak to their day-to-day functioning. And we also compensate the informants for their time to get those assessments done. Medical comorbidities that might accelerate risk of cognitive decline in AD and ADRD risk are also more prevalent in our cohort. So it's really important that some plasma biomarkers that might be more affected or elevated by chronic diseases such as renal disease or diabetes, etc., are addressed. And so in order to address this potential problem, we obtained additional funding in order to run clinical chemistries on everybody so that we could evaluate that with more caution in our group. We bumped into educational disadvantage on neuropsychological assessment. So as you can see, our Black and African American individuals, even though they reported 12.8 years of education on average, really had about an 8th grade reading level. And so in order to address this, number one, we measured literacy on everyone, but we don't use it as a criteria for inclusion, because the last thing we want to do is set another barrier for participation. Instead, we developed video-assisted consenting. We implemented the teach-back method to make sure that people understood what they were consenting into. And we also, of course, co-vary for literacy in a lot of our analyses. So to do this work, of course, it's very laborious. It's also very fun. In October alone, we have had 18 events. The month isn't even over. And by the way, a lot of these events now are by invitation. They invite us. And what do we say? Yes, we will be there. So our model is one of broad and inclusive outreach. In 2024, we have already participated in over 80 community-based events, including faith communities and community centers. And this really has allowed us to build relationships, being a source of giving, being a resource to our communities. This has caused a ripple effect where a lot of motivated individuals that are community leaders have taken on this work and are doing a lot of the work for us within their own communities. It's really deepened our engagement with the communities, and it's building a sustainable academic community partnership. Beyond our work in the ADRC in Miami, we have developed the mobile Alzheimer's disease risk evaluation. We call it the MADRE, which we plan to implement in a collaborative study. And this is a model that was designed to facilitate comprehensive assessment in the comfort of the participants' homes or community centers. And it's fully computerized to reduce participant burden and increase standardization and ensure that data is captured efficiently. And very importantly, everyone, it implements novel and cross-culturally validated cognitive tests that are able to map onto AD/ADRD biomarkers. That is very important for our field as we move forward and select tests for our diverse populations. So some of you might recall this famous movie, Field of Dreams. It came to my mind, this famous phrase, "If you build it, they will come." Do you remember that movie? This is that old paradigm of engagement of the ADRCs. It really highlighted this belief that engagement was centered upon this wonderful center that you can build, and people, it's so valuable, and people are going to be naturally drawn to it, right? But we have another model that we suggest, which is, we'll meet you where you are. And that's where I would like to encourage all of you to meet your participants where they are. And I thank you for your time, and I just want to thank everyone that helps me do my job every day. I have a wonderful team. Alex Ortega, who's here with me, Dr. Rundick, thank you all for your time, and I look forward to the panel discussion.
Thank you, Dr. Sid. What an impressive presentation. You certainly have set up high standards for the rest of us in terms of diversifying our clinical core cohorts. So thank you. Our next presentation is by Dr. Kathleen Poston. Dr. Poston is an endowed professor of neurology and neurological sciences at Stanford University. She's also chief of the Movement Disorders Clinic division at Stanford. She's a member of the Stanford ADRC leadership and is director of the Stanford Parkinson Foundation Center of Excellence. Her studies focus on better understanding of the motor and non-motor impairments in patients with alpha-synucleinopathies. She has obtained significant funding to conduct her research and uses functional and structural imaging biomarkers, as well as studies the genetic basis of these disorders. Please join me in welcoming Dr. Poston to make a presentation. Thank you.
Well, thank you all so much for inviting me here. It really is just an honor to be able to speak to this group and to talk about something that I've been spending a significant amount of time on over the past couple of years, specifically the last year. So here are my disclosures. So imagine with me for a moment that a 50-year-old woman walks into her primary care doctor's office, where they talk about cardiovascular screening, they talk about the risk of heart attack, they do biomarker profiles, and come up with a personalized plan to prevent cardiovascular disease, heart attack, and stroke. They talk about cancer risk, maybe genetic factors, exposures, and come up with a personalized screening plan to prevent cancer in the future. They then discuss neurodegenerative risk, talk about exposures, genetics, and come up with a personalized plan to prevent neurodegenerative diseases of aging. This is the future that we all of us really hope for, that neurodegenerative diseases of aging will join cardiovascular and cancer screening in the preventative space. Unfortunately, for those of us who have been treating patients who are predominantly affected by diseases that are characterized by aggregated alpha-synuclein, this hope has been very, very far away. And that's because we haven't had biomarkers to truly identify individuals who have this potential disease prior to the onset of symptoms. We have been a very symptom-driven subfield because we haven't had biomarkers to tell us who does and does not have synuclein disease independent of their symptoms. So this is where we live, is we live here where these symptoms are quite pronounced. We've been able to get a little bit earlier when symptoms first developed. Based on a couple key prodromal symptoms, we're able to come up with cohorts that maybe are at higher risk due to things like REM sleep behavior disorder, hyposmia, or even constipation. But within these nonspecific symptoms, we've had a very hard time truly identifying those individuals who would go on to have symptomatic disease. And so by having potentially a biomarker, we can move this forward. And what we've also come to realize is that this idea of synuclein-driven disease really is a combination of cognitive, sleep, motor, autonomic, neuropsychiatric, and sensory symptoms, which have a variety of clinical terms, from Parkinson's disease, dementia with Lewy bodies, Lewy body disease, Lewy body dementia, PD dementia, prodromal PD, and prodromal dementia with Lewy bodies. We use all of these terms to talk about people who have this constellation of symptoms, which is predominantly guided by what time they happen to show up to clinic and what clinic they happen to show up in. There's an enormous amount of bias in naming something based on which clinic they showed up in, when in fact at autopsy, the predominant finding is that these individuals have aggregated alpha-synuclein within the neurons. And so with this new biomarker, the seed amplification assay, we've been able to begin to identify individuals who we believe have alpha-synuclein aggregated pathology in the neurons in individuals during their life. And this is just showing some of the early data. We think there's some evidence that this assay can separate individuals with predominantly neuronal from predominantly glial. There's actually a new manuscript, which I'm not part of, but I just heard yesterday was accepted to Lancet Neurology that shows kind of the next phase in this ability to separate out patients with glial versus neuronal synuclein with the seed amplification assay. And now we have, and this is sort of for now, right? This has been the gold standard for now. But in fact, there's a lot of new developments, as was mentioned earlier, of additional ways for us to identify alpha-synuclein in individuals who are alive, including immunofluorescence assay that's being done in skin. There was a fabulous manuscript in JAMA Neurology earlier this year that really showed robust results from that cohort. And there are numerous other attempts at moving these biomarkers into blood, as well as other peripheral media, which I think will be absolutely essential if we're to move this into more generalized audiences. In addition, as was mentioned, we also think about neurodegeneration in this regard, and with dopamine imaging being the most specific biomarker for identifying nigrostriatal dopaminergic degeneration in these individuals. But that's again for now. There are many new tracers that are out there that have a better specificity for dopamine, as well as possible CSF and blood-based markers that might show evidence of nigrostriatal neuronal degeneration that could be used in this place. And so with this, my colleagues and I put forth this proposal of a neuronal synuclein disease, which simply was defined by the presence of individuals who had this predominantly neuronal alpha-synuclein and dopaminergic neuronal degeneration, simply letting us for the first time try to identify living patients who might have what we would expect at autopsy to be called Lewy body disease. That's really this was the purpose of this entire process, was simply to start this. And in fact, iteration was I think probably the most commonly used word when we were putting this together, is that this was really something that needed to evolve, not just in the ways that we identify synuclein, but possibly subtypes of synuclein that make certain individuals more likely to progress with a cognitive first versus a motor first syndrome, better markers for dopamine imaging, as well as a lot of other neuropathologies which we know are evident in these individuals, but we simply don't have good biomarkers to identify them yet in individuals. And so we really view this framework as a very first version, sort of like that baby turtle emerging from its shell, making its way to the ocean. These are first steps, but I'm reminded that big journeys often begin with small steps, and that's where we really see ourselves, is with the very, very initial phases of this process. We also recognize that the majority of individuals who are seen both in research as well as in clinic will not have availability of these biomarkers. They're CSF-based, they're SPECT-based, and so for now, continuing to use the clinical terms for diagnosis will be appropriate in most patients, both in clinical work as well as research, and the coexistence of neuronal synuclein disease and the clinical diagnosis in the contextually appropriate way is appropriate. We are not suggesting to replace the word Parkinson's disease with neuronal synuclein disease, but simply using NSD as a way of identifying people who we know have the biomarker positivity independent of their clinical picture. And that gives us a much easier way of exchanging ideas and using language. And so I'll just end with a little bit of data. This is from the PPMI cohort. So on the y-axis is the dopamine imaging, and so below that horizontal line are people who had an abnormal DAT image. On the x-axis is their smell test using this University of Pennsylvania smell identification test. To the left of the vertical is an abnormal smell, and the closed circles are the people who had a positive CSF SAA, and the open circles are the people who had a negative or not detected SAA, and we're currently looking into that group of individuals right now. It is worth noting that about 1/3 of individuals with a LRRK2 mutation do not show aggregated alpha-synuclein at autopsy, and it does seem as though those individuals do not show a positive SAA. Again, that manuscript is currently under review. A substantial subset of those who are hyposmic or have REM sleep behavior disorder also seem to have a positive assay. And importantly, about 93% of those with REM sleep behavior disorder who are hyposmic also have a positive assay. And it seems as though the assay precedes the abnormality on DAT, but we're currently enrolling a cohort within PPMI of synuclein seed amplification positive individuals, DAT negative, and following them to see if that sequence of events is in fact correct. This is a hypothesis that clearly needs tested. We have a little bit of autopsy data. So we have 22 individuals who are enrolled in PPMI, so that was at the time of their Parkinson's diagnosis prior to the onset of medications, who have now come to autopsy. These individuals had a positive seed amplification assay at diagnosis and were found to be Lewy body positive at death. These two individuals were seed amplification negative at the time of their Parkinson's disease diagnosis. Retrospectively, the CSF was banked. The first one, the clinician changed the diagnosis to MSA 3 years in, and at pathology was confirmed to have glial synuclein, or was glial cytoplasmic inclusions. And this individual was later found to be a LRRK2 carrier, and at pathology was found to have nigrostriatal degeneration with no Lewy body disease. So in 22 patients, just 22, I know we need a couple more zeros after that for this to be valid. In 22 patients, it's 100% concordant. And so finally, who are those SAA negative individuals? We've been looking at that, and we don't have, again, we only have autopsy on one of them so far, but if we look at their progression to worsening symptoms, we see that they actually, the SA negative individuals are in the blue survival curve here, whereas the SA positive are in the green. We see that they progress to more aggressive milestones much quicker. We believe a good number of these probably will have MSA at autopsy, but TBD. In the biofinder cohort, cognitively unimpaired individuals who are SA positive were far more likely to progress to a PD or DLB diagnosis. And it turns out that those who had co-pathology were much more likely to progress to a more aggressive dementia syndrome. And so I will not go through this in detail. I will let you all read the paper, but just to see that we put together the staging system, again, as a framework right now, just to show as people move through the clinical severity with regard to the biomarkers. Unfortunately, by the time we get to here, where patients have a fully expressed clinical syndrome, we do not have biomarkers currently to tell us the severity, right? We don't have a tau PET scan to show us how extensive the pathology is. We just have this binary outcome. So a lot of work that needs done, particularly in this form of the stage. But I think critically, what this will allow us to do is to move from this post-mortem construct of Lewy body pathology, mixed pathology, and AD pathology, and these clinical syndromes where we know we have individuals with mixed pieces, some with mixed pathology, some with only Lewy bodies, which right now is separated by time. And to finally, at least within the context of living patients, to be able to start to put them into their biologically focused areas where we can look at those individuals who seem to have exclusively Lewy body, those who have more of a mixed picture, and those who actually we thought had Lewy body disease but really only have AD biomarkers, and start to actively study these individuals during life. And that is something we hadn't been able to do previously. And so this is really a first step. And then finally, we've really tried to harmonize this with the efforts that are going on in Huntington's disease and Alzheimer's disease, because what we truly believe is that as we continue to move along, and co-pathologies are the rule, not the exception, that we need to be able to think about these biomarkers together. And I really want to encourage all of you, if you do read the paper, to focus maybe on panel 3, because that's the most interesting panel. Those are the open research questions that we think are the most important to address. And what I would love is for the ADRCs to tackle some of these really important research questions that we need to answer within this context. So I will end there, and I want to specifically thank the Michael J. Fox Foundation for funding these the efforts and really putting forth the vision. And I also want to thank the Stanford ADRC, which from its very conception included individuals across the Lewy body and the Alzheimer's spectrum and recognized the importance of co-pathology. And that's obviously been a very important part of my career, and I thank them for that vision. Thank you.
Thank you all. So now we are going to transition to our panel. I'd like to welcome up to the stage Dr. Gil Rabinovich, who will be our motivator, as well as Dr. Lejoie, Dr. Kirill Sid, and our two virtual presenters, Dr. Eddie Lee and Ganesh Babalal, and then one more in-person panelist as well, Astrid Suchi Dicey.
Thank you so much. What a great series of talks. So just to introduce our panelists, Dr. Astrid Suchi Dicey is co-lead of the University of Washington ADRC Data Statistics and Methods Core and has done some really exciting work on American Indians that hopefully she can share with us during the panel. Dr. Ganesh Babalal from Washington University is an associate professor, PI of several studies there, and a member of the NAC Scientific Review Committee. And Dr. Eddie Lee is associate director of the Penn ADRC and leads the neuropathology core. So welcome to our speakers and our panelists. And please, for all of you, if you have questions, I see people are already lined up at the mic. Maybe we'll start with one of the online questions and then go ahead with the microphone. Thank you.
Sounds great. Our first question is from Dr. Pete Nelson. Some roles for biomarkers are to provide insights into prognosis, clinical management, pathology prediction, and clinical trial recruitment or stratification. Can you comment on the potential for using genetic data to help in these contexts?
Maybe Kathleen, did you want to start with that, with Parkinson's Lewy body, and then Renaud or others could go with Alzheimer's?
Certainly. I think within the context of Lewy body disease in particular, genetics is extremely important, since we do know we have these genetic variants which do not result in aggregated alpha-synuclein that we could tell, at least based on current stains within the brain. And so certain genetic subtypes do lend to a different pathological picture that we don't fully understand. And so I think within that context, we are really encouraging the incorporation of understanding the genetic data in addition to the biomarker data, that should be thought about in a broad spectrum.
Yeah, and I think the same applies in the Alzheimer's field. Especially when it comes to amyloid biomarkers. For example, when you think about the autosomal dominant forms of Alzheimer's disease, we know that biomarker, the amyloid pathology can be a little different in some specific, associated with some specific mutations. PET scans might not be able to capture everything the same way. The relationship between fluid biomarkers and PET might be a little different. So I think in those specific autosomal dominant cases, you need to think about, you really need to think about biomarkers slightly different. The other thing is that the genetic data is also part of the new routine assessment for patients who are being evaluated for anti-amyloid therapies. And I think ApoE is such an important role, has such an important role, not only for the risk of dementia, but also the risk of ARIA and everything. So we need to think a lot more about genetics now that we have this treatment as well.
Thank you.
I could add in.
Oh, yeah.
Can you guys hear me?
Please.
Okay. Also thinking, even in the autosomal dominant genetic causes of disease, that there still is a lot of disease heterogeneity. And so a third of presenilin carriers still have alpha-synuclein disease. And some of the worst Lewy body cases I've seen have granulin mutations, for example, and there's a link there. So it's not going to be, it's just going to make more things more complicated and richer, and it's not just black and white.
Great. Let's take some questions from the audience, please.
Hi, Gwen Garden, University of North Carolina, Duke UNC ADRC. Should NICRAD be doing seed amplification assays, and if so, on everyone, on a subset? What do you think?
That's a great question. So we have been, myself along with colleagues within the the PPMI cohort, have been working with individuals across multiple different cohorts really in the world, and kind of making the case that if you have stored CSF in individuals with good detailed neurological data, I think it's really, really important to consider adding a seed amplification assay to that. There was a call from the Fox Foundation over the summer. They funded a handful of studies from dementia cohorts to healthy older cohorts to RBD cohorts, et cetera, to add SAA to that as a first step, but I think it would be a wonderful addition to the ADRC data.
Tatiana, not to put you on the spot, but did you want to respond to that at all?
So I'm glad to. So I also, so for those of you who don't know, I work in the PPMI study and also bank with them as well. So
she's our neuropath co-core leader.
Yes. so I would say, let me put a couple answers to that. CSF is what at this point is the sample that you need to have in order to do seed amplification assays. Personally, what we've done is we've had really good relations with Amprion that is able to do that both in a research lab and in their CLIA laboratory. They're really ramping up their ability to turn around data. So honestly, from our perspective, the quality of the data and the speed with which they do it, we've been happy to rely on that. I think the question in my mind will come if we're able to get a blood-based seed amplification assay. We're also working with them in the context of skin. So part of it is around, again, in both cases, I would argue if we get to ourselves to a point where that's the tissue, I think we would see ourselves in NCRAD in a position where that would be important for us to be able to do. That's certainly our opinion at this point. I hope that's helpful.
Thank you. Great. Charlie, and then...
Yeah, I'm just going to continue in this discussion because I think the seed amplification assay is really turning out to be incredibly important, and because not only, as you pointed out, that it seems to be, or actually Sanjay said this is very specific, but you're also beginning to speciate it. So I think, so my question to you is, when I'm talking to a patient, it's a little bit, okay, do I say, hey, get the skin biopsy, it's relatively easy, we don't have to do an LP, but it's going to be lacking some things. And if it's negative, do I go to a CSF, or do I just say, forget skin biopsy now that we have the seed amplification? And your thoughts on that?
It's a really good question. From the context of where we are, I think the predominance is doing this in research, and that was definitely the recommendations from the manuscript, that we were not recommending people apply this yet to clinical use, even though both of these are available clinically. That was not the recommendations from our first iteration of the paper. That said, I've sent over 500 CSF samples from my research cohort. I've sent 5 from my clinical cohort, right? So that's kind of the balance that I have between those. I think if you are considering testing for synuclein in the clinical context, I think understanding the question you're asking is the important piece between the skin versus the CSF, because the skin assay, it's an immunofluorescence. From what we can tell, it cannot distinguish between predominantly neuronal versus predominantly glial. But if your patient, if your question is, does this person have a behavioral variant FTD, or is this an unusual dementia with Lewy bodies, or it's sort of in that realm, then you're not thinking about MSA, right? Yeah. And so in that case, the skin biopsy might get you to your answer. But if I'm seeing a patient who has, has some gait abnormalities and a positive DAT scan, and I'm thinking, gosh, is this going to be MSA versus PD? Then I have to go. So understand what the test can get you, and then the clinical context, I think, is the most appropriate thing. But I would say, again, 500 to 5 is my ratio for research to clinical.
Well, thank you. That was an excellent answer.
Please.
Yeah, I just want to comment briefly on the issue of anti-A beta targeting and the extent of our ignorance on that issue. We've seen a couple cases now, one at I'm Rudy Castellani at Northwestern, by the way. So just from a couple of cases, we know that these drugs do engage their target. That definitely happens. And we're told that they engage soluble protofibrils, but we also know now that, and we really can't see that under the microscope, what we can see is targeting of insoluble A beta, both in the parenchyma and in the blood vessel walls. We know now that these drugs don't distinguish parenchymal A beta from vascular A beta. So in those individuals with cerebral amyloid angiopathy, where you're basically infusing a vasculitis, And it probably it represents at least a percentage, if not most, of cases of ARIA. And just to last for the clinicians, we learned the hard way that when a patient has had these drugs infused and presented with stroke-like symptoms, infusion of TPA is a very, very bad idea. So just keep that in mind. So more research is needed for sure, and don't underestimate the toxicity, particularly the vascular toxicity in people with cerebral amyloid angiopathy that is very difficult to diagnose during life. Thanks.
Thank you for those comments. Maybe I'll ask Eddie to comment on this a little bit. So how can the ADRC, and others on the panel can join in, but how can the ADRC program really help with this incredibly important objective of bringing individuals who are on these new disease-modifying therapies, either through clinical care or in clinical trials? How can our network help address the huge gap in getting more cases to autopsy and really understanding what these drugs are doing at the molecular and tissue level?
Yeah, it's been, so even if we take a step back, even just treating patients has been a heavy lift. Scheduling all the testing that needs to be done and getting the infusions done. I think the good thing is we have the infrastructure in place, and so at Penn we've been trying to raise money and submit additional funding to deeply phenotype a treated cohort, and hopefully they live forever, but we'll capture the few that come to autopsy.
Yeah, maybe just a show of hands, how many ADRCs are currently allowing people on these therapies or who have been in trials to stay in their clinical cohorts or are recruiting them for their clinical cohorts? Just see a show of hands. So this is, I think, such an exciting time. I'll say UCSF also. So this is such an exciting time in the field as our ADRC network is moving, I think, from observational to maybe a little bit more of a network of interventional studies. Tom, please.
Yeah, so I'd like to raise two questions to the panel. Following up the comments about area risk, our field really, in the AD side, needs a biomarker that's specific for CAA amyloid as opposed to plaque amyloid. And what are the prospects for that? And then secondarily, for both synuclein disease and AD, what's the prospect of a reliable oligomer assay for CSF and plasma, since that are the most toxic species that we're going after, and that's going to be critical for assessing what we do at the end of insoluble amyloid removal. So how do we manage those patients long term?
Yeah, the question about CAA, it's really interesting because when you go back to the biomarker development, both for the fluid biomarkers and the PET, in the early days, before the treatment came to the clinic and before it became really so relevant to be able to detect CAA, we didn't really, I don't think anyone really investigated this so thoroughly. And I think now everyone has extreme interest in identifying, and being able to quantify CAA in vivo beyond what is done with just the MRI sequences right now. That is, helpful, but probably insufficient. So we need to go back to those pathology imaging, pathology CSF studies, and go back and really focus on the CAA and distinguishing the CAA part to the parenchymal amyloid. Yeah, that's.
So for the CAA, we recently published a paper in Actor identifying CAA-specific protein biomarkers by proteomic studies and immunohistochemistry. But obviously, those need to be extensively validated.
Anything to add from the panel on CAA biomarkers? And I think the next part was on oligomers, right? And open this up to the audience as well, since we have so many experts in the room. But does anyone on the panel want to address the issue of biomarkers for oligomers?
All I can say is that's been a very hard thing with synuclein. We are not close, but I think it's an important area to go after.
Thanks. Sanjay.
Yeah, thank you. You know, I wonder if this might be the right time to have some discussion on the promise of dried blood spots when it comes to biomarkers for alpha-synuclein and TDP-43. At least the CNS panel has over 120 analytes, and some of them may be relevant to the discussion we are having here. A lot of work needs to be done in that area, but that technique has true promise when it comes to biomarker assays. I wonder if the panel may want to make a comment. Perhaps Tatiana, maybe Sterling has some experience, may want to say something. But this is a really fast-moving, way of collecting plasma in a most non-invasive way. So just thank you.
So I know there have been some efforts recently in more, so not quite to the dried blood spot, but sort of the in-between phase of the remote plasma collection where you can send the device and it collects. One of the key things, even in that transition, is to understand that you're collecting capillary blood and not true venous blood, and to make sure that whatever plasma markers we're saying we can get from plasma can also be obtained from capillary plasma, that they're not exactly the same and the protein content is different. So doing that head-to-head comparison, I think, is a really important next step, and then ideally taking like the next step and can we get to the even remote, but I think we need to take this stepwise. But the key thing is to understand that blood is not blood is not blood, and the way you obtain it will influence your proteins that you are analyzing.
So, go ahead, Renee.
No, I just wanted to add that I think the head-to-head comparison is very important. One thing that we're that we're thinking about a little bit is try to not validate a biomarker based on another biomarker that is based on another biomarker that in the end is based on neuropathology. At some point, we can't get too far away from the standard of truth, at least if we want to be able to interpret the biomarker like this. So I think having head-to-head comparison of biomarkers against a gold standard that we understand is going to be very helpful. And it's not specific to that question, but to any new biomarker development.
So maybe this is a good point to transition a little bit. And to me, the great promise of blood, and maybe the blood spot even, brings us to your talk, Rosie. And instead of having people come to our centers to get PET scans and lumbar punctures, thinking about meeting people where they are, can our panelists talk a little bit about what your thoughts are about blood biomarkers? Is this really a game changer in terms of being able to study more representative populations? Are there additional barriers that we're not thinking about, for example, with American Indians that you've worked with, Astrid? So maybe we'll start with Rosie and Ganesh, who haven't had a chance yet, and then and Astrid to hear your thoughts about that.
My thoughts are that I believe that there's a tremendous promise in the blood biomarker space. We haven't had difficulty whatsoever with blood draws, much less with the fasting bloods when we go to them in the morning very comfortably. It's more likely that they will comply with that rather than having to reschedule the visit or, for another time, that they remember to fast, etc. So I believe that it allows us to be able to acquire the biomarkers. We've been very successful with acquiring blood, but we have to also be very careful in making the interpretation of that in these populations without a lot of the validation still against PET for underrepresented people, that we don't have enough validation, let's say, of something like p-tau217 that is so exciting and so promising, but we still have to validate that against PET in our cohorts. We can't put the cart before the horse there. We have work to do.
Do you want to add, Astrid, or share your perspective?
I would definitely agree with that. I think that one of the additional things we have to think about, and that we do, I think, often have to consider, is the availability of samples, especially in stored samples. They're enormously valuable. What little we have collected is limited, and so having assays that are available that use much smaller sample volumes is obviously beneficial. I think that the point of blood is not blood is not blood is really especially relevant for this group. That I know that our great talks earlier pointed out that
there's a lot of comorbidities in these groups. And so kidney disease, which can really influence blood biomarkers, measurements is very common. Diabetes is very common. And so a lot of these comorbidities and confounding factors in assay measurement are a key factor, and I think would need to be considered in validation efforts as well.
Sure. Ganesh, did you want to share your perspective on some of these questions we've been grappling with?
Certainly happy to weigh in. So we have an African American only cohort called the ARCHES study that's recruiting middle to older age African Americans, and we decided not to do your traditional PET amyloid or PET tau or CSF acquisition within the sample, and did pivot very strongly 3-4 years ago to collecting blood. And we're now able to actually collect blood in our participants' home or at a community center where we're doing testing. Just in regular chairs, we're able to keep it on wet ice for roughly about an hour, get it back to the lab, centrifuge it, and the integrity of it is still retained as we're either storing it for long term or getting it processed. So I think to answer your question, Bill, it certainly is a game changer in terms of its ability to acquire that in places beyond the academic institution.
Thank you. Question from the audience.
Hi, Randall Eck from the University of Washington. Thinking of like the TM106B fibrils that have been discovered in several neurodegenerative diseases, do you think we're missing like disease-relevant co-pathologies right now that either could contribute to disease or influence biomarkers?
Yes.
Yeah, and I think we need to remain very humble about what we know and what we don't know. Late is or TDP-43 of aging, or however you want to call it, was not something that really knew about 20 years ago. And I think it completely changed the way we think about a patient who's older, amnestic, and slowly progressive. I think it really changed, and I think we need to remain very humble. It might happen again, and hopefully that will lead to a better understanding of what's going on.
So this brings me to your figure, Renaud, with the hemi-neglect and just seeing the right side of the image. Maybe I'll ask some of our panelists. I mean, Kathleen, thank you so much for coming, and you've generated so much excitement talking to us about alpha-synuclein. How close are we to biomarkers for TDP-43, be they fluid, imaging? Will we be able to have a director's session about the new TDP-43 biomarkers in 2 or 3 years? Maybe I'll start with Eddie. Eddie, what do you think?
I think I'm very hopeful. So there's work on the neuroimaging side where you can look at how much tau does somebody have versus their structural MRI, and if there's a mismatch that might be associated with TDP. There are PET, glucose PET measures out of Mayo Clinic that highlight that. In terms of fluids, there's this pretty amazing paper actually by Anya Schneider earlier this year looking at plasma extracellular vesicles where not only detecting TDP-43 in cases that presumably have TDP-43, but also 3-repeat tau versus 4-repeat tau. And so that's actually looking at the TDP protein itself. And then there's new work showing that when you have TDP-43, your splicing goes awry and you start generating new proteins, these cryptic peptides, and we're detecting those now. So it really reminds me in the early days when people were just being able to detect A beta and tau. But I think with the pace of science that I think, everybody needs to stay tuned. I think it'll move fast.
Anything to add?
I think maybe one point that came to mind, and it's also because of trying to spend time with neuropathologists and understand how they work and how they come up with a diagnosis, and when there's multiple things going on, how to find a hierarchy of what is likely to be a primary cause of impairment. One thing that we'll have to think about to really understand, once you have multiple biomarkers that are positive, to kind of get a sense of how much of the decline could be attributed to different biomarkers, I think we'll need to have quantitative biomarkers. And I think this is my complete and honest bias about neuroimaging, is that we do get measures that are quantitative and that give us an idea of the burden. And I think that the development of the new alpha-synuclein biomarkers is incredible. And I look forward to a day where maybe we have something that is a little more quantitative so that we can gauge things a little better.
So Rosie, I was really struck by the diversity of Miami-Dade County, and the people that we lump together into these very coarse categories of race and ethnicity. So, I'd love to hear from our panelists, how can we think in a more sophisticated, advanced way about these social determinants of health and the populations that we're not capturing in the ADRC system? Which populations are we missing? Maybe start with Rosie, and I'd love to hear from Astrid and Ganesh.
Sure.
As well.
I think that it's very important to, people here essentially know this. They've been hearing it for years. The Hispanics are not monolithic, right? They're from very different regions of the world. They have different practices. They have the common language that unites them. There's a lot of cultural things that unite them. Perhaps ancestry, etc. But for example, I am from Miami, born in Miami. My parents are of Cuban descent. We are from Spain. So essentially, I'm European. Dr. Ortega was born and raised in Mexico, and she is, I'm sure, of a more a Mexican, descent in a more pure way than me, from an ancestral perspective. There's a lot that brings us together. We were just joking last night, very late, working over my slides. We were just joking that we're also so different in very nuanced ways, in the ways that we would approach things. So please remember that Hispanics are not a monolithic group. So examine who you have. And if it's not good enough, there's a collaborator in here for you. So for example, as diverse as our population is, it's not diverse enough. Why? Because only 2% of the population in Miami-Dade County is Mexican. And so who'd I call? My friend Suda. And I said, hey, I think we could be better together, right? And so this is something that you really need to do, examine who your cohort is. Our cohort of African Americans are individuals that were mostly raised and educated in the segregated South. This is very different than an individual that was, kind of born and raised and educated in the Northeast or in Chicago, etc. And, how they perform on neuropsychological tests, how they approach things like brain donation, or whether or not they're willing to get a skin punch biopsy, that's very different. And so we'll have different approaches. So I'll let the others comment.
Astrid.
Yeah, I would echo that. I think everyone here would probably recognize that American Indians and Alaska Natives are not one people. There's over 570 federally recognized tribes. We have a study that involves 13 of them and have a lot of collected data, but that's only 13. That's a very vanishingly small proportion and is not representative nationally. And of course, we're missing Native Hawaiian, Pacific Islander, a number of the island nations that are a part of the United States, Puerto Ricans, and other peoples. And so we're missing those entirely. And so, having better representativeness, having nationally representativeness, but I think also I think you mentioned this, thinking about where they come from. One of the things that we think about a lot in our center is how are our different racial ethnic groups coming into our center, because of course our clinical population, which is majority white or non-Hispanic white, is different from the groups that we access by going into the community and accessing community-based groups. And so the causal-based inference in comparing those two groups, the community-based recruitment and the clinic-based recruitment, is going to be confounding that racial-based comparison. And so we have to think about that. And of course, that's a really important consideration when we're doing this epidemiologic research, and so we have to think about that a lot.
Ganesh, I know you've thought a lot about these topics, both where people are being recruited from and how we're lumping really very diverse individuals into single categories. Love to hear your thoughts on this.
Certainly. Well, I think Carrie Gleason has done some work on this. A lot of you in the room have done work in this area, looking at the representation of the ADRC population, especially across race and ethnicity. We're stuck with using the United States Census OMB classification, and it's an archaic, crude system that doesn't capture the lived experiences or, more importantly, the heterogeneity of our population. And when we're thinking of forecasting, looking to 2050, when the world we know will become more significantly diverse, and especially here in the United States, I think we need to start focusing on intersectionality. So right now, the NIA Health Research Framework identified 9 priority populations. I think 2 of those were mentioned were Hispanic Latinx and Native Americans, Alaskan Natives. But again, not everyone fits really neatly into one specific race or ethnicity. A couple of years ago, Nina and I were on a call where we were looking at Asian American representation in the ADRC network, and it's kind of low. A lot of that is due to Asian being the model minority, and that myth itself, I think, has harmed the recruitment and retention of that specific group in our research. Now, when we're looking at the world, Asian represents 60% of the world population, and it's diverse across countries, languages. And so one of the things that I probably would recommend is when we're starting to think about diversity, don't just focus on race and ethnicity. So think about language, think about nationality, and specifically think about the intersections between all of these when we're looking at truly understanding mixed pathology, which was, I think, the topic of this session, right? Because there are certain facets that we're not collecting right now that may not necessarily show up on a PET amyloid scan, or it may not necessarily be a consensus diagnosis that's been derived by a group of experienced clinicians, right? And so the more noise that we have, I think, will help to refine a lot of the discussions that we're having right now.
So the folks at NAC will kill me, but maybe as we're rolling out UDS4, it sounds to me like we really need to think for UDS 4.1 or 4.2 about capturing so much more of these dimensions, right? Not just these crude categories, but really much more about the lived experiences and the true diversity of the samples of our research participants. Eddie, it really occurs to me that also in our sort of standardized neuropathological assessment, we're very much focused on aggregated proteins in diseases that were neuropathologically primarily defined in European populations. And I'm wondering, what are we missing in terms of comorbidities that might apply to more diverse populations? And how do we sort of extend our thinking about neuropathology to capture maybe more of these heterogeneous mechanisms of disease that won't be captured by traditional Brock staging or tau synuclein, Thal staging of A beta, et cetera?
The honest answer is we don't know what we're missing, right? We just don't have the cohorts, the postmortem tissue to really know what's going on. I'd say even within BRCA staging, there's a lot of heterogeneity, and so there are more quantitative measures. But the big thing is that Alzheimer's disease is pretty stereotypically spreading through the brain, and so we know where to sample and what to look at. But there are diseases that are more stochastic and heterogeneous, and so things like postmortem MRI, where you can get a more global picture of cerebrovascular disease or white matter disease, or there's no diffusion tensor weight imaging yet for postmortem, but working on things like that, I think, can supplement autopsy pathology and get a bigger picture. I think if we're not open to seeing stuff, we're not going to see it. So we have to just be open to seeing other things. We've seen in the PEN cohort that there is a relationship between area deprivation index and cognitive function, but that is not due to amyloid and tau or any other pathology. So we are definitely missing things, and we just have to keep looking to see what it is.
Yeah, so maybe instead of thinking about, one standard of truth, which is neuropathology, and validating everything else, maybe, we will really advance our understanding of disease by integrating all of the different tools that we have, tools that capture social determinants of health and adversity through life, fluid biomarkers, getting back to the oligomers and things that are, capturing things that may not be apparent when you're looking at an autopsy sample. Obviously, neuropathology being very important, imaging, which can sample the entire brain as opposed to just a select few areas. And so maybe it's, rather than thinking about these, as this is standard of truth and everything else is striving to capture that, we can start to think more about multimodal data sets that can really advance our understanding. Any other questions online or from the audience? All right, if not, I'd like to thank our speakers and panelists one more time. Thanks to everyone for a great day.